Well, thank you so much, Mariah, and welcome everyone. On behalf of Dr. Dallas and myself, I really want to express our appreciation for your attendance today and for the opportunity to share some thoughts with you about the topic of learners and development of professional identity. We would invite you to participate. We have about 40 slides, which we'll zip through probably in 40 minutes or so if we stick on the 1 minute per slide target we've set for ourselves. We do want to invite your participation through questions or comments. If you want to make a comment, you can either type it in the chat, or if you feel so inclined, well, please unmute yourself and just ask your question at any time. We want this to be as interactive as is possible in using a Zoom format. So with that, we'll hop right in here. Paul and I are going to tag team it, so we'll be passing it back and forth, and would invite your participation as you feel so inclined. So here's our objectives for today. We want to talk a little bit about the concept of what is now known as professional identity formation, and explain a little bit about why this is highly relevant to both the education process for physicians as well as ongoing practice. We want to talk a bit about the stages and influence and how this is developed, the professional identity of a given learner, how it is developed over time. Look at some factors, both internal and external, that might shape one's professional identity. And finally, attempt to apply this concept to some real life scenarios or clinical dilemmas. So that's where we hoped to go today. This is an ambitious set of objectives, but we'll do our best to hit the target on each one of them. And we have nothing to disclose. This is a favorite way I like to disclose the fact that we don't have any conflicts of interest related to this presentation. And in fact, I often say, being a medical educator, I wish I could eventually have one of those, but funding is scarce for this sort of thing. So that being the case, we have no relevant conflicts of interest to declare today. Paul.
So, you know, there's the issue of professionalism and the issue of professional identity formation. Professional, you know, what is a doctor? What is a professional? How do you develop being a professional, first of all, and then how do you have it? Well, Henry David Thoreau, if you guys ever remember reading him on when he lived at Walden for a couple of years and wrote a book called Walden, reminds us that in his preface he says, I shouldn't use the word I so much and talk about me so much. If there was anyone else I knew better. Well, we'll use a lot of examples, and there'll be a lot of I's here, when I, and so forth, because we've seen medicine, we've seen medical school, we've seen students and residents and faculty. And I wanted to share two instances with you that harkens on professionalism. One, you cannot ever underestimate a mother's wisdom. And I can remember when I was in residency a long time ago, I was at home and I was doing some yard work, and I was dressed in raggedy clothes, and and I had a hat on, slathered in sunscreen, and the hat was dirty from years of not being clean. And so I had to go to Lowe's to buy something. And she stops me, she says, "Where are you going looking like that? You can't go out there. You're a doctor." Somebody will see you. So there's an expectation that you look like a doctor, right? We'll talk a little more about that later. So very wise in professionalism. And just the other day, a good friend of mine shared with me that a patient of his, after he had examined him, talked to him, examined him, and so forth, sat down in his office, says, finally, this is a person who'd been a patient at Korea for a long time, a real doctor, he says. So there are explicit and implicit expectations of what a doctor looks like. This is one of my favorite paintings here, the doctor from 1871. Here's a professional looking doctor. I guess we can all agree to that. And unfortunately, he's sitting at the bedside late at night, beside a child whose little hands and body were weakened by disease. The mother, if you can see it, it shows up on your screen, is in the back with her head, her head weighed down with angst and grief, and then the father in the background standing stoically. if I sit long enough with this picture, it makes me a little bit tearful. But we have expectations of professionalism, and how you identify that and how you become that is a big question for us here today. David. So a lot of has been written since the 70s, 80s, mostly 80s and 90s, and we'll borrow quite heavily from the scholarly work of Cruz and Cruz from McGill. This husband and wife team were prominent figures in medical education, particularly for professionalism. And they published their seminal work in 2018. Next. So defining our terms, professionalism versus professional identity formation, which, we may not have heard that term before. Next. Professionalism is a set of values, right? It's how we behave. It's our relationships. It's what makes us trustworthy to the public as doctors. This is what the Royal College of Physicians published in 2005. And it's the framework, it's a larger context for discussing how we identify ourselves as professionals, how we define or form a professional identity. By the 70s, 80s, and 90s, we saw a lot of discussion about this. Back in those days, in the 90s especially, you saw the American College of Physicians and other organizations put out scholarly work and white papers and books, even whole books on the fundamentals of professionalism. And actually, in 2002, the American Board of Internal Medicine and the American College of Physicians, the ACP, the ABM, and the ACP, discussed three fundamental principles of professionalism: patient welfare, autonomy, and social justice. And we want to remember these words because we'll come back to talk a little bit about them through examples, actually. So patient welfare, we need to be competent. Okay, we can't practice medicine without being competent. It's part of being a professional. We need to be honest. No one's going to say no, be dishonest. I'm chuckling because we'll talk about a case where that was the case. Maintain confidentiality, patient autonomy. We'll come back and discuss that a little bit. Social justice. What are our professional responsibilities to society? How do we maintain trust? How do we keep up with the new scientific knowledge? So, moving on, as I mentioned, a little history, 80s and 90s, because the thought was we weren't being professional enough. There were some threats. The charter we just mentioned, and led to an examination of how we transmit these values from one generation to another. When I first started working here, back in the early 90s, well, 91, January the 2nd, 91 to be exact, it struck me that I had to write things down for my residents on the wards. Do this for pre-rounding, do this for attending rounds, do this for whatever work rounds. And because I thought, why doesn't everybody know this? How did it get to me, but it didn't get to them? So these values that may or may not have been, I don't want to use the word cast aside, but may have been somewhat colored differently, are embodied in the word professionalism. We haven't taught it explicitly. It's been transmitted by role models. Like I said, I found that I had to actually teach it explicitly. I'm in the process of just this morning writing down how our residents should respond to their patients for labs. So I realized that they weren't responding in the way that I always thought was the correct way to do it. And the thought was that role models alone were no longer effective. Maybe it's because we don't see role models anymore. They come in for a second, and then we watch them on on YouTube or something like that. I heard of a medical school recently who uses YouTube to teach physical diagnosis. It killed me. I love physical diagnosis. I had to take the knife out of my back. That we were now teaching physical diagnosis in medical schools through YouTube. We can talk about that more later because that's something I would love to get off my chest. So next.
I think this is me, the next couple. So the result of this history so far seemed to be that late 90s, early 2000s, that we kind of reached a consensus that we could no longer depend solely on role modeling or more passive forms of teaching, that in fact we needed to be more explicit about teaching the concept of professionalism to our learners, our medical students, our residents, fellows, even early faculty sometimes. So one of the results was this was the development of curricula throughout the continuum of medical education that included both content knowledge and methods of instruction as well as assessment. And so when you put together a curriculum, obviously you have to have a cognitive base for that, which meant that different specialties and different organizations defined professionalism, what it meant to their particular discipline, their specialty, and also talked a bit about how medicine should relate to society, which goes back to what Dr. Dallas just mentioned, the so-called social contract between medicine and how medicine relates to the public and how medicine addresses the public's expectations of medicine. And all of this was brand new. This was not something that had been really talked about all that much, but it really became an item during this period of time. And I think that the assumption underlying a lot of that was that if we led our learners to have a greater understanding of professionalism, that this would result in them behaving in a more professional manner. And of course, the jury's still out on that in some cases. I think, and often it's true, and maybe sometimes it's not so true. Simply understanding something does not necessarily lead to a change in behavior. But nevertheless, this emphasis on teaching and promoting and assessing professional behaviors really moved the emphasis to doing professionalism. How do you do that? And how does that work itself out in terms of what a physician does every day during practice? And then finally, in this regard, all of the major accrediting bodies that you see listed there for the medical school education, residency education, on into the American Board of Medical Specialties, and even in other countries, the accrediting standards began to reflect this requirement that various programs had to develop their definitions of professionalism and then demonstrate how they were teaching their learners and assessing them on their professionalism, which is especially the assessment part is not easy to do. Back to you, Paul.
We talked about how this added emphasis or increased emphasis in the past 20 to 30 years, but it goes back longer than that. Okay, you know about the Alpha Omega Alpha Honor Society. It's an honor society for medical students. It was actually started in 1902 by this fellow William Webster Root, plus a number of other medical students in Chicago. And the reason they felt that they had to start this because they looked at their classmates and they said this. He said this: honesty was conspicuously absent, and behavior in the halls and classrooms was rough and boorish. That's an amazing condemnation of the status of medical students, of the state rather, of medical students and medical education. And I want to concentrate on that word honesty because remember the charter talked about honesty, well, that was very, very key. And they also wanted to make sure that people were professional, that they were leaders, that they were scholars, that they were involved in research and community service. We think community service is a recent thing. We want to do community service because, for the good of the community, but also because Dr. Music wants us to do it for advancement. But it's old, right? It's old, and people saw that there was a need for personal and professional honor and dignity and integrity. What Alpha Omega Alpha actually means is right there in the Greek, action ofedintus avundas. And for those of you who read Greek, I apologize for not including the correct breathing and accent signs there because I couldn't get my computer to write them. But it actually means worthy and it's translated "be worthy to serve the suffering" in the Alpha Omega Alpha website, but it actually means worthy, not be worthy. You are worthy. You are worthy to actually better the situation, or to advance the situation, to improve the situation. Tus algundas, and algundas is different. It means pain, as an algia, right? Neuralgia, arthralgia. And it's different than odynia, like odynophagia, or whatever. Odynia is specifically pain. Algundas has a spiritual component to it. It's a spiritual component. So imagine if you put that all together, what they were looking for in a physician. It's much more than what we anticipate the physicians today as professionals. Next. And it goes even further than that, right? The Hippocratic Oath. There were doctors all over the place. There were barbers, right? People who cut, and you didn't want people who cut. They shouldn't have been doctors. They were something else. So this idea of professionalism actually goes back 2,500 years. What it is to be a professional, what it is to be part of this profession, what it is that your identity should be like in this profession. And it started off with an oath, right? I swear by the Apollo god and Hygeia and all the appropriate health-related gods of the time. And I want to call your attention. These are the standards for it. You can read through those and return to them if you like. But professional conduct, the fourth one down, expectations for professional behavior, for honesty, integrity, respect for colleagues and the medical profession. Respect in such a profound way that you respect the person who taught you this profession and are dedicated to passing along those skills to their sons. And this is what they say at that time was sons. With younger generations of doctors, and fostering that community and that continuity of medical practice, the duty to teach. I discovered this profoundly when I first came to Roanoke, and I was trying to get our residents to go to certain locations, and I had an attending tell me, well, I'm not interested in teaching at all. And I thought, how can you not? It struck me as odd. How can you not be interested in passing along the knowledge that someone else gave to you, the sense of responsibility for the next generation?
Okay. So I think I have the next few. And so all this leads us then to look a bit at the literature and say, well, what do our current colleagues, what do our more recent colleagues have to say about this notion of professional identity in medicine? Our comments have focused mostly on the concept of professionalism more broadly, but now we want to make a little bit of a pivot to this more specific and recent interest about professional identity formation. Exactly what does that mean? Well, here's a couple of definitions from the more recent literature, both in about 10 years ago. Dr. Heidi Wald at Arkansas, I believe, talks about this being the development of professional values, moral principles, actions, and aspirations, and ongoing self-reflection on the identity of the individual. And then also in that same year, Crossley et al. Said the extent, professional identity really means the extent to which an individual feels like a member of the profession of which they intend to become a part. So do they feel like a physician? That's actually quite important, and we'll come back to that a little bit. More recently, the authors that we've depended on quite a bit, Cruz and Cruz, along with some colleagues, said that professional identity is really a representation of self achieved in stages over time during which the characteristics, values, and norms of the medical profession are internalized, resulting in a person thinking, acting, and feeling like a physician. I think this is, for my money, the best definition that I've run across in the literature. I think it covers everything because it talks about the person's achieving this identity over time during stages and gradually internalizing the values and norms of the medical profession. So we often ask our students, do you feel like a physician? I know I've done some coaching with students recently, and it's part of a new program here. And we talked about this a little bit. At what point in time do you feel like a physician? I'm working with first-year students, and they almost always tell me, no, not yet, but it's coming. they're starting to assimilate some of the values and the characteristics of a physician already. The medical school has actually paid quite a bit of attention to this in the last couple of years as part of our recent efforts to revise the curriculum. And I want to call out particularly Dr. Jed Gonzalo, our Senior Associate Dean for Medical Education, who has worked on this along with Dr. Leslie LeConte and some other colleagues. And this is currently on our webpage. There's a link there. You can go visit and learn a lot more about this if you'd like. We've always talked about some of these things, but I like the way that this new identity has been put together. You see at the middle, in the middle part there, you see, we hope to graduate people who are patient-centered physicians. And what does it take to get there? We hope that they will be lifelong master adaptive learners, as well as system citizens and scientist physicians. So this is our school's most recent attempt to spell out what we think it means when we're trying to have our students adopt this professional identity. And I won't bother to go over this in great detail, but if you go to that web page or other web pages, you'll find that we have paid a lot of attention to the general area of professionalism with one of our competency domains, as well as a number of objectives there, accountability and self-awareness and seeking help. And all of these things are grounded firmly in the literature that we've very lightly reviewed just in the last few minutes, talking about professionalism and how that has to work its way into a person's professional identity. Also, the accrediting body for the residency and fellowship training world, the ACGME, has also put together what they call their 6 general competencies. If you're a physician with us today, I'm sure you've heard this before. And one of those 6 general competencies is spelled out there. Again, talking about professionalism and how part of one's identity as a physician means that you will demonstrate some of these types of characteristics shown here. So again, our friends Cruz and Cruz put together this nice graphic, which I think combines a lot of these things into one picture, if you will. And they talk a lot about the physician as both the healer as well as the professional. So you see the aspects of both of those things here. And then when you put them together, you have these things that overlap between the two. And it's like the way that they put this out in a very nice graphic that's pretty easy to follow. So professional identity formation is really a lifelong process. It's something that takes time, and it requires us to think about it over a long period of time, I think, with our learners and on into residency training and practice. So I guess the person could say, looking at this scale, if over here to the left, you're a layperson, and all the way over to the right, you're a physician, a fully fledged practicing physician. It's interesting to ask our learners, where are you on this journey of 1 to 10? Where are you on this scale? And we ask a couple of rhetorical questions here that we'd probably like to hear from you on if we have time. Are we equipped to teach these topics? And how do we create significant learning experiences where we can teach these topics and involve our students in some direct learning experiences that touch on this idea of developing their professional identity?
Which leads us to, this question. It's clear from the Cruces and from Ruth and from Hippocrates that we need a professional identity. We have to have a professional identity in this profession as professionals. But how can we address the need for learners to develop that professional identity? They're clearly not professionals, on that scale. They're a layperson at one, and then at some point they become a physician gradually, and then they're it. So it's like there's an old story of someone asking about when he was going to change. Something happened in his life, and a wise hermit said, come up with me to the rooftop at 12 o'clock at night. And they sat there and didn't say anything. The wise person didn't say anything to the learner. And next thing you know, it was about 8, 9 in the morning. It was light. He says, when did we sit up here in the dark? Now we're here in the light. He says, when did it actually become day? So there's that gradual time when it became day. One was clearly dark, one was clearly light. When it became day was a significant question. So it's a goal, right, that we have to teach professional identity formation. There's a shift from faculty teaching in which the learner learns passively, perhaps, to learners being actively engaged in developing their own professional identity with support from peers and faculty. That's what Cruz and Cruz said. You know, we have to dissect every word. It's very important because we're asking learners or people who are developing to develop in their own way. Well, how do they know how to develop? It's kind of an interesting question, but it is a goal that we have to have for ourselves. Next. So what are influences on professional identity? Personal experiences, probably from potty training all the way to medical school and residency. I think it all fits in there about how we become professionals. David and I were talking about this the other day. If you ask physicians in their 50s if they feel burned out, 50% of them feel they're burned out. If you ask third-year medical residents, they feel burned out, 50% of them feel they're burned out, and I'm being a little loose with the numbers. Interns, how many of them feel burned out? 50%. Well, okay, you can understand the person who's been practicing for 20 years how they might feel burnt out, and maybe you can understand why the intern feels burnt out because they're working very hard. If you ask students, third-year students, 50% of them feel like they're burned out. And then same thing with first-year students that have practiced no medicine. And I told David, I said, David, I think we're just picking the wrong people, to be doctors. We're picking people who are likely to be burned out. It's a personality that we're shooting for, and maybe it comes with a certain type of desire to be successful. So a formal curriculum certainly can influence our professional identity. We need to be careful of that hidden curriculum and the role model, because you may be role modeling correctly, you may be role modeling incorrectly, and that plays a big part of how professional identity is influenced. What about your mentors? Students and residents were asked about what they wanted in a mentor in one study, and if you ask interns what they want in a mentor, what they want in attending, they want an attending who can teach them how to do things. If you ask the residents, they want an attending who has the encyclopedic knowledge. I want to go to Dr. So-and-so, and he's going to tell me everything I need to know about X. But if you ask students what they want in an attending, it's a person who teaches them how to be a doctor. So this mentorship concept is very, very important. What about peer relationships, right? One may ask the question if it's the blind leading the blind in peer relationships as far as professional identity. But in one study, 65% of what a resident learns, it's because they learn from another resident, not from an attending. And we'll need to let that sink in for a second. What about organizational culture? We change our culture because of whatever we're told to change our culture for. But there are little micro cultures, and then there's a big macro culture we want to impart to our learners as professionals. Some learners have a great deal of self-doubt. I don't know if I can be that, and that influence, I can be that doctor. Had one resident tell me one time, it was in the clinic about 30 years ago now, and the student says, I love my internal medicine rotation, but I don't think I want to learn medicine that well. So I'm going to go into family medicine. Let that sink in for a little bit. I want to be a good doctor, but I don't want to be as good a doctor as it takes to be like this. I want to be less than that. And then also whatever happens in moral distress or ethical dilemmas that may happen during your career. Next. So remember community. We talked about that already with Ruth and with Hippocrates as well. So what are the expectations that our community has? We belong to various communities. Physicians do, professionals do. Medicine, in its broadest sense, our subspecialties, the health system that we work in, the internal medicine department versus the surgery department. Are we educators primarily or researchers primarily? And the residents and fellows and the students they need to join this, in which you've heard the word internalizing it. And once again, we put it in quotation because you internalize these concepts and what the values are and what the norms are for this particular community. But they need to be made clear and explicit so we all understand that that's exactly what we're looking for them. Next. So when does it happen? Dr. Music said it was a continuum, and it certainly is. It's hard to tell. You can tell day, you can tell night, but when does it come in between and happen that way? We don't know. But sometime probably in pre-medical school to medical school is probably a critical time when you're pre-med and you're at the greatest university in the United States, which, by the way, is the University of Virginia. For those of you who are questioning.
I might have a second opinion on that.
Okay, there you go. I'm sure. I was hoping somebody would give me some pushback. Some Virginia Tech alumnus. Oops, I forgot we were Virginia Tech. Okay, sorry. And into medical school. Then, you know, how you transition from medical school to residency, because there's that thing now. I'm a doctor. I gotta act like one. So you know, this change, this identity formation happening in stages. I was reminded of a medical student I had many years ago who was quite an arrogant young man. I love this guy. In first and second year, you couldn't teach him much. By fourth year, he spoke at the convocation at graduation, and spoke, you know, so eloquently and memorialized a colleague of his. And I sat there and I was awed by his eloquence and his clear thought. And I thought to myself, he's become a doctor. He's become a doctor. You know, third year, maybe took a little bit of the edge off his arrogance, and he become a good doctor. So we develop it during residency and fellowship. Then we go into practice and we learn a little bit more. Sir William Osler said it takes 10 years after graduating medical school for a person to start to become a good physician. 10 years. I used to quote that to folks when I was younger. I said, I haven't become a good physician yet because I haven't been out of residency 10 years yet. So it's lifelong for certain. It's self-directed, but other things direct us as well. And we learn to adapt. Next. What are some of the strategies that we can use to foster professional identity formation? Well, we'll hear. It should be an educational objective. If we find that it's missing, then we should put it in our curriculum. We see that we talk about it and we have that at VTC. And perhaps we need to make sure it's intertwined in teaching on professional, not only the global professionalism, but the subset of that, which is professional identity formation. Faculty need to learn this better. Faculty, you know, when we were pushing out the portable ultrasound curriculum, it was clear everybody wanted to learn this, but we needed to teach our faculty first before we taught anybody else. And this community that we practice in needs to be supportive of this through various events and rituals, and we'll talk about one of them here in a little bit. Next. So what are the challenges in teaching professionalism and teaching professional identity formation? Maxine Papadakis in the New England Journal of Medicine in 2005 did this wonderful study. They looked at unprofessional behavior in students and then asked the question, what happens to them later? And in her study, she showed that unprofessional behavior in medical students, they were 3 times more likely to do so in practice as well. And if they were defined as having a lack of responsibility, either for their learning, for their classwork, for showing up on time or whatever, the odds ratio was 8.5. Well, imagine that. I mean, that puts a mark on them. So maybe they did develop some of the things before. Maybe as like a tiger, we know a tiger doesn't change their stripes. They're deep. There may be some challenges there because how do we change something that may not be changed in some people, or may be difficult to change in some people. And what she discovered also was that when the students were defined as being apathetic, so there was apathy and poor initiative, and it also correlated in a big way with multiple disciplinary actions later. We have a program called Residents at Risk in the internal medicine residency program. And these are residents who score below a certain number on their in-service training exam. And we know that it correlates with their ability to pass the boards 1, 2, 3 years down the road. And I can recall a resident that we had who was smart enough. But he had some of these concerns, poor initiatives, apathy, lack of responsibility, and he was assigned to me in the residents at risk. And it was clear that he wasn't interested in getting any better. And I remember saying at one of our meetings, he's going to be a problem. He may not be a problem for us because we'll get him through this. We will make sure that he passes his boards. And the prediction came to be the following year, he was kicked out of his fellowship program for the same behavior that he had while he was here. And that happens for residents, but also happens for faculty. If you look at the CME literature, faculty that have been defined as difficult, when you put them through multifaceted CME, a multifaceted CME program to see if they improve, few of them improve. So the question is, when it's ingrained, is it too late for change? Is it too late for change? I don't know the answer to that question, but I pose it because we've seen examples of it. So moving on, is it too late for change? How are people going to change? Are people going to become professional? Or they're going to develop an identity? There's an article I used to share. It's in 1991 now. I used to share it back in the days when we used to pass out articles to House officers. I used to pass this one out on my ward months. Do House officers learn from their mistakes? Well, there was a survey of 254 House officers, only 114 completed, well, about half. And, an anonymous survey about mistakes that they made. And these mistakes were significant. They were mistakes in diagnosis or prescribing or evaluating or communicating or procedures. And the serious outcomes in 90%. These weren't subtle mistakes. Deaths in 31% of cases. And they asked, what was the difference? Those residents who accepted responsibility, that's a professional, element, right? For mistakes and discussed their mistakes, they were less likely to make any mistakes again, and they weren't likely to report constructive changes. But those residents that did not make constructive changes did not do so because they attributed their mistake to job overload, to I didn't get enough sleep, I'm worked too hard, it's someone else's responsibility. And if they felt like there was a judgmental atmosphere, they were less likely to report changes. One might wonder whether the judgmental atmosphere stemmed from them inward to outward, or whether it stemmed from outward to them inwardly. So we see why you can develop, or how you can develop, by actually taking some responsibility and maybe being able to change, and that's what we hope for. Next. So another study in 1994, I quote this all the time to the residents and the students. Why do doctors get sued? Why do patients sue their doctors? This is out of the Lancet in 1994. And they say that they sue the doctors because they want to make sure there is a standard of care. Can't help my dad now, but I want to make sure you guys follow a standard of care. Honesty. Remember we talked about honesty in that charter? Physicians still get sued for lack of honesty. Patients want explanations and communication. Compensation was on the list, of course, but it wasn't as high on the list, and not so much that it needed to be punitive compensation, but it needed to be cover costs. Accountability. There was one case in which I was involved as a malpractice witness, for the defense, where the surgeon who was responsible for the mistake during surgery, sat down, talked with the patient's family, the patient passed away, um, and took responsibility and held himself accountable. And they didn't sue him. They sued the hospital. They sued the nurses. They sued the janitor. I don't know. They sued everybody, but they didn't sue the doctor who took accountability. And what were some of the keys in another study for why patients sue their doctors? He never talked to me, one person said. He never examined me. Have we ever seen that before? Didn't put his hands on me. Didn't present himself as a doctor. There's all kinds of professionalism stuck in that statement. And one person said, I didn't like him from the first time. I wanted to sue him from the first time I saw him. I was waiting for an excuse, which came 5 years later. So not only do they define what the doctor looks like as a professional, but they also have in mind what they're going to do to him if they fall from that professional, pinnacle. Next. So what is it? What is, finally a doctor, I put in there health doctors, professional doctors, and this is what in the Google, right? Because you always got to access Google, and this is what you get. Now I'll call your attention to the top row, second from the right. There's some people there that you might recognize who come up in that search. But what is the common thing you see? Most of them are wearing white coats. Most of them are wearing stethoscopes. No one is wearing a headlamp anymore. There used to be a sine qua non of physicians wearing a headlamp. We have pen lights now, obviously, and whatnot. And it's got to be the right stethoscope, by the way. It can't be those little chintzy ones that you got. You got to have a nice in cardiology to look like a real doctor. So this is what people expect. And maybe we changed our expectations of what doctors should look like. Next slide. So the white coat, right? What happened to the white coat? Marcus Welby wore a white coat, but House didn't wear a white coat. One could argue, if those of you have seen watch TV, which one you would like as your doctor. One is phenomenal physician, but has a bunch of rough edges, including an addiction, and that's the one on the right. And then Marcus Welby, of course, is the perfect doctor. So it's symbol, right? It's a symbol of professionalism. When you enter into the profession, you get a white coat, right? Medical schools have it. I was just at the graduation ceremony for the doctors of physical therapy, and they were doing their white coat ceremony as well. These white coat ceremonies, a lot of aspirational, a lot of inspirational words, a lot of Latin, occasionally some Greek for the really erudite. And they put on the white coats. And it always struck me that the people who are wearing the white coats have wrinkled white coats, and they're wrinkled in a fashion that says they've never been out of the box before. When David and I were talking about doing this talk, he says, yeah, we can challenge him. He says, but some people might be triggered. I hope I'm triggering some people. You can tell me, later. So what is this message that we're sending? People expect a white coat, and we're saying wear a white coat, but we don't wear white coats. Is it something we want as a legacy, or is it lip service? I know that's a little polemical there, but I'm happy to provide you with that intro.
Thank you, Paul. Appreciate your comments and thoughts as always. So again, we kind of wrap up this section by thinking a little bit again about what are the strategies we can use to foster our learners to think more about their professional identity. We've mentioned some of these already, but guided reflective practices. Reflection is really one of the key tools, I think, in this area. We ask our learners to reflect on what they've learned at various points in the process, and particularly related to different issues related to professionalism or ethical concerns or things like that. Mentorship and coaching programs we've talked about, as well as peer support and role modeling. We also need to do, I think, a better job of addressing leadership training and developing future leaders for particular roles within medicine and the health system. And then finally, to address well-being proactively. We hear a lot about well-being today, and Paul talked about that earlier. But I think it's important to be out in front on that because it is a very serious issue for our clinical faculty. So having said all that, how in the world can we measure this idea of professional identity formation? Well, I have to tell you, there's not much out there about that. There's a little bit, but we tried our best to find some particular ways that we could suggest for further exploration on your part. And so I think the first thing to say is that it is difficult to assess professionalism or identity formation at the level of the individual. You know, we do a lot of these type of ratings in the group setting. So our curriculum here at the med school uses problem-based learning quite a bit. And I think if we had a PBL preceptor here with us, they could probably agree that it's fairly easy to address how a group is doing, but it's a little more difficult to address how each of the 7 or 8 students in the PBL group is doing, particularly on the area of professionalism. So we have a lot of different ratings that we try to use in this regard, mostly in the clinical setting. In internal medicine, they've had something called the mini clinical evaluation exercise for quite some time. We have end of rotation evaluations. We have 360-degree ratings where people on the healthcare team can rate each other on various aspects of performance, and that could include professionalism. And then many schools are going to a portfolio-based approach where they ask you to compile over time a significant number of reflections and ratings and other assessments of how you think you're doing and how others think you're doing with regard to your professionalism. Here's a couple of examples from the literature. This was a study from 2021, so just about 4 years ago, and it asked learners to kind of self-reflect at various points how they feel about being a physician. So you can see the first question, I feel like I'm a member of the medical profession. Number 4, I'm pleased to belong to the medical profession. Number 7, I feel characteristics with other members of the medical profession. So the idea here is you give them this and ask them to fill it out at various points in time, and then you track it over time to see if it changes. Somewhat similar to that was a different study about 10 years ago that was based primarily on reflective exercises. So students were asked to write about their insights about professionalism and professional identity formation. This involved both medical students as well as dental students. And here's some of the questions that they were asked. What else? You know, it asks about how has your professional self-identity changed over the past year? Thinking about particular courses, what has had the greatest impact on your professional identity, and so forth. So you can see here, there are some ideas out in the literature of how one might do this. A lot of it is based on self-report or evaluation by an expert in the clinical setting, which again can present some challenges. So we don't have the answers in this regard for sure. We're just throwing these out there as potential areas for further exploration.
So much work to do from a scientific perspective of questionnaires or what have you in evaluating, but what about, you know, measuring by example? Because, you know, while, you know, one thing is an anecdote, you know, many anecdotes don't necessarily mean data, but we sometimes think it does. So I wanted to share with you a couple of experiences I've had here, as well as from other institutions. But you know, we talked about the word autonomy, right, in the charter, and I was practicing this early on in my career. And I went to a lady who's intensive care unit. She's 89 years old, and she needed a carotid endarterectomy for carotid artery stenosis. And I laid out all the information for her, and she was looking at me with her eyes glazed over and said, "I don't want to hear any of that. You're my doctor. You make the decision." So we need to be careful with autonomy so it doesn't, you know, move into abandonment. You know, so you know, it's all about the autonomy and teaching it. And ongoing self-reflection is so important. We talked about it before. Nipsis is the Greek word for being aware. And if you're not aware, that one patient who one day I didn't tell her that she needed to lose weight. And she started crying. I said, "Why are you crying?" She says, "Don't give up on me. Just don't give up on me. It's the first time you didn't tell me that I needed to work on my weight." Responsibility. We saw that personal responsibility. You know, one of my residents one time said when I asked her about why she hadn't responded to her labs to her patients, she goes, "Are you not seeing the results?" I thought, wow. Well, I know I'm seeing the results. The question is, are you developing that identity as a professional to see those results? And not only personal responsibilities, but professional responsibilities. a case once that I defended in with as a defense witness, where a patient wasn't little bit. I mentioned this to the student, the resident head, just discussed the timely results, the lab results when I share with the patient. Patient didn't think he got the results in timely fashion and sued the doctor. So role model, we talk about good role models. This was and Chad, if he's still on here, may remember this, but we oftentimes bemoan the fact that when our residents are looking for internal medicine programs, they're also applying to other programs, and they don't necessarily tell us about that. So one of the program directors, I don't know what institution, she started says, I tell them to do that. So in essence, I tell them to be dishonest, to apply to several programs and not tell anybody that they are. And you can imagine if you're that role model, what you're passing. This is the hidden agenda, which brings us to the next slide. You know, what is that hidden agenda that program may have or an institution may have? I recall one time when we talked about value and balance in our profession, we were doing a budget, and I was off on Mondays, and so the budget meeting was on Monday, and I remember being asked to come in on Monday, my day off. I thought, well, I'm going to practice balance here. I'm not going to come in, but where is the hidden agenda there? What about July residents? A secretary shared this with me at another institution where 3 people had gotten together. She was in earshot of him. And they said, remind me to stay out of the hospital in July. And I thought, wow, amazing, because you're responsible for teaching these students, but you don't think you taught them well enough, whether it's, knowledge or professionalism, that you want to actually be taking care of them. And you want them not to be taking care of you. Or another person that was shared with me where a student was not behaving appropriately, and they didn't give her the guidance, but said we couldn't wait for her to actually leave the service. And I think that there are many other examples that we potentially could share, but we're coming to the end of our time here. And David, maybe we can end up with the questions.
Sure. So I hope this has at least stimulated some further thought. Reflecting on our presentation, we've tried to summarize where we think the literature is on this concept. It's so new that we couldn't come to a whole lot of firm conclusions, particularly about how the best way is to teach this. We made some suggestions, and also in the area of assessment, which I think we just barely started to scratch the surface. So hopefully this has been somewhat thought-provoking for you, and you can continue to explore this on your own. In support of the CME credit, we have a couple of questions here that we want to ask you. And you can answer these either verbally or probably not, just in your own head. But the first one says true or false. Both are true or false questions. Professional identity formation, while not a static concept, is nonetheless fully formed by the time a physician finishes residency training. True or false? And then the second one says some retrospective studies show that unprofessional behavior by medical students can be predictive of future disciplinary actions involving practicing physicians. That was something Dr. Dallas talked about. So here's the answer. The first one is false. We tried to stress that this is a concept that doesn't finish when one is not complete when one finishes the residency training, but rather continues on into practice. And then the other statement is true, that Dr. Dallas talked about the Papadakis studies, how unprofessional behavior can indeed be predictive of future disciplinary actions. We'll end with a little bit of a humor here. I like these despair.com slides, if you've ever seen some of these. And this is an example of what I would say anti-professionalism, or not really grasping the concept of professionalism. Somebody just painted around the tree trunk there. So at any rate, that's all we have. I'm sorry we didn't leave as much time for questions, but we do have some time. And Mariah, I'll pitch it back over to you for the last few minutes.
Yeah, fantastic. Thank you guys so much. I think you gave everyone a lot to think about. A question in the chat. Why do students and residents want to be called by their first name and not Dr. Jones?
Hmm.
That's an interesting question. When David and I were talking about this the other day, I recall being in medical school, we were all referred to as doctors. The attendees were referred to us as doctors, and we weren't a doctor. And then there was this move toward being called student doctors. They were called student doctors. This is student Dr. Dallas. This is student Dr. whatever. And why is it the students that are preferred to be called by their first names and the residents, or is it the programs that are doing that for them? I don't know the answer to that question.
Okay, let me jump in here, Dr. Dallas, and say I asked that question because I teach your first year medical residents one day in my free clinic. They always say, I'm Joe. And I say, well, what's your last name? I say, in my clinic, you have to go by Dr. Jones or whatever. Because the patient needs to know that, who you are. I mean, we have so many volunteers, we have so many students, variety of people who see my patients. I want my patients to know who is the doctor. But they kind
Faith,
of
I agree with you.
they kind of push back on that. I think, where have they learned this? Anyway, I felt like a doctor the first day I got into medical school. I was so excited, and maybe we're picking the wrong students if they're not excited to do this. If they're going to burn out, really burn out, that's craziness. Why would anybody burn out? They just need more sleep, maybe. But I think if they burn out in medical school, maybe we picked the wrong people. That's sorry, I just had to say that because you said,
this is one of those. Yeah, this is one of those topics that I think requires Dr. Harrington's input as a psychiatrist, because it has a lot to do with your psyche and cathartic.
People with the wrong psyche.
Yeah.
Dr. Henderson, did you have something to add? Oh, must have been an accidental unmute.
I was going to say, in the clinic where I go, I occasionally encounter a medical student, and they are still introduced, at least sometimes, as student Dr. Jones or student Dr. Thomas or whatever it might be. So that phrase is still around, and I always appreciate that. I'm getting to the age now where I can't always tell the residents from the medical students. So good for somebody to tell me.
I think it is important for all of the residents to be referred to that way. Actually, one thing that Dr. Dallas kind of alluded to that I find more, in the 15 years roughly since I graduated, is that the residents aren't always given the opportunity to quote unquote get their doctor on. They're actually asked to sort of defer to higher levels. You got to ask the fellow. Oh no, the fellow's got to ask the attending. And pretty soon what happens if you train in that kind of environment is that you don't internalize that professional identity that I am the doctor. So everybody gets called student doctor in third year because I want them to get used to it. And I can understand why they might say, you can call me John. There's another good reason, which is that if everybody is referred to by their surname, there can be no question that I called Sally because she's a woman, and I called Dr. Jones, who happens to be a man, Dr. Jones. So it really avoids some of the pitfalls that I might run into as a physician with learners. And so I think that's just an important concept. Everybody should be referred to by their surname. It helps them to get their doctor on, helps them to, I think, take in that professionalism. And there's one other piece that they also, I just think, Dr. Dallas, have been taught a little bit more, that having worked in urban populations before I came here versus more rural populations, I think that patient said, you do what you want, doc, I trust you. That kind of paternalistic trust I often don't see in other populations. So I think that if we have to be cognizant of kind of a middle road, it's, because if you don't give people the options in front of them they'll say that you were a paternalistic jerk. Somebody will. You're never going to find that person that sort of deferred to authority and said, do whatever you think is right, Dallas, is mad at you for saying, okay, well, if I was treating you like my mom, this is what I'm doing. That's all.
I had a colleague who was doing a history and physical for a retired 4-star general. And he was a little bit scared of the retired 4-star general, who was also a physician, and didn't do the rectal exam. So Greg goes back to the on-call room. He gets a call from the program director, who had gotten a call from the 4-star general and said, your resident did a poor evaluation. He neglected to do the rectal exam. He wasn't professional enough. And I thought it was amazing, because he recognized the fact that there is things that physicians need to do. And yes, I agree with you. We don't necessarily we're not necessarily practicing the same medicine with every patient as far as how we come across. A good physician is a coach. If your player is playing well, you may just give him tips. If your player is not playing well, you maybe because they don't have the ability. And so you need to know that. So you need to know who your patient is, so you can provide them with the care that they actually need at that time.
I'm not to cut you guys off, but we are over the hour. So if folks need to leave, thank you so much for joining us. And we appreciate your time. But there is another question in the chat if Dr. Musick and Dr. Dallas have a minute to respond to the last one. Fantastic. From Dr. Adkins, how do the values demonstrated by our healthcare organizations surrounding medicine as a business or productivity-based employment models sculpt the professional identity of physicians and learners?
David?
Well, boy, that is quite a question, and it probably deserves a seminar of its own, Farrell, just to be honest with you. I think it has a profound impact, personally. Now, I can't say that from experience because I'm not a clinician, so I don't work in that context. And Paul, you certainly can comment on that. But I think it has over time, I think we've seen a shift, maybe a subtle shift from medicine as a profession to more of medicine as a business. So I'll give you one out of many concrete examples. I was sharing this with Paul last week when we were talking about this. The use of the term provider is a very business-oriented term. I do not like that term. I have tried my best to eliminate it from my vocabulary because I know many, many clinician friends who do not like that term. They are not a provider of a service. They are a professional rendering a service, and there's a huge difference between the two. So I think it's had a profound impact, and I don't think it's necessarily always been bad, but I think some of it has been somewhat negative. Paul, what do you think?
Well, I agree with you. I think the majority of it has been negative. The other day, you had a resident who, lady came in with dysuria, okay? And so the urine was negative, so it meant that she had to do a pelvic exam. And that's what has to happen. Okay, that's we got to look for things that you can only find there. And of course, very conscientious resident, and she was like so busy. She's like, oh, I don't have time to do a pelvic exam in this patient. And I remember feeling that as a resident too, where I had to get finished. I had to see all these 17 patients in this walk-in clinic or whatever. And so this productivity and this throughput pushed her into almost not making the right decision. Turns out she ended up having a sexually transmitted disease, which would not have been figured out unless she had that pap smear. So yeah, I think it has been negative, and also seen this concept. Well, insurance ain't going to cover that. So and so ain't going to care if I put in this special time. So why do it? I'm not saying that's correct. I'm just saying I've heard that. I've seen that in national discussions. Have discussed that with American College of Physicians and other places. Awesome.
thank you all again for giving extra time to us today. We really appreciate it. The CME link was shared in the chat, so please use that to get CME credit or just to give us feedback on the session. And Dr. Musick and Dr. Dallas, thank you so much for leading us in this discussion today. We really appreciate your time.
Thank-
Pleasure. Thank you.
Wonderful rest of your day, everyone.
Take care.
Take care.